Good morning. Welcome to In the Trenches with David A. Cohen. Today's topic is going to be pericarditis. I'm going to give a quick talk on this. This is inflammation of the pericardium. It should be noted most of the time with pericarditis, the myocardium can be involved also, and you have myocardial pericarditis. So, as far as pericarditis, what are the causes? Causes most commonly viral, idiopathic, the viral Coxsackie echo adenovirus. You can see it with CAD, post-MI. You can see two types of pericardial effusions. You can see it acutely with an MI, and then 2 weeks to 3 months later, you can see Dressler syndrome, which is an immune reaction. So you can have it acute, and then you can have Dressler's. You can see it post-CABG, post-bypass surgery. This is not uncommon. Pericarditis, you have to think of connective tissue diseases. The most common one you think of is lupus. You can see it with rheumatoid arthritis. You can see it with other connective tissue diseases. You can see it as part of the spectrum of the aortic dissection. With trauma, you can see drug-induced pericarditis. Hydralazine, procatamine, minocycline, drugs that could cause lupus. These are things that you need, and then you can see pericardial events which could inflame the pericardium. Often it's viral or idiopathic. That and the ischemia are the big things, and connective tissue disease. How do you diagnose it? They have chest pain. The chest pain classically is relieved by sitting forward. They also might have a pleural effusion with this. They may have pleurisy. You can have pleural pericarditis, period. EKG, theoretically, there are 4 stages in the EKG of pericarditis. First stage, you see ST segment elevations. Now, these are usually diffuse, and if you look at this, the ST segments are usually concave up. If they're concave down, more consistent with ischemia, more consistent with ST segment elevation MI. So you have the concave up. They're diffuse. The other thing you see is PR depression, and very few things do this. And this is what's known as spodicide. So stage 1, you have ST segment elevation, PR depression, then they normalize, then you have T wave inversions, and then that normalizes. Okay. What type of problems could you get with pericarditis? It's often self-limited. The concern is if you develop a significant pericardial effusion, and once in a while you can get cardiac tamponade, especially with aortic dissection, acute aortic dissection. That's how people die. And you need to make sure you follow the patients for this severe exam, check for pulsus paradoxicus, neck vein distension, muffled heart sounds. You obviously don't want this to happen. Now, usually that does not happen with pericarditis. Okay, now how do you treat pericarditis? There are usually 2 components to the treatment: non-steroidals and colchicine. Once in a while, steroids are used if you can't use anything else. The problem with steroids, you get a rebound in the pericardial symptoms when you stop the steroids. The non-steroidal that has the best data is Motrin, ibuprofen, and high-dose ibuprofen, like 800 milligrams 3 to 4 times a day. It should be noted that patients with cardiovascular disease or renal disease or heart failure cannot tolerate this. If it's a young person who has idiopathic or viral pericarditis, that's a different story. The other drug is colchicine, and colchicine could be given acutely, and they're stretching out. They're giving this for months afterwards. They used to give it for a month or two, and it's being drawn out. The two studies I'm aware of with good data, the ICAP and the COP study. One is acute, one is more chronic, but the treatment are usually non-steroidals and colchicine. If somebody has a pericardial effusion, it may need to be drained. If they have tamponade, they may need a pericardial window. That's basically pericarditis in a nutshell. You need to recognize it. It's chest pain, often relieved by sitting forward. You're going to go through the differential. In a young person, you're going to think idiopathic or viral. You want to evaluate for a connective tissue disease. There's also an association with MI and cardiovascular disease. Post-cabbage, we used to see this a lot. They're not doing as many cabbages now. And the treatment, non-steroidals and colchicine. And with that, I'm going to stop. Thank you.